Hi everyone, I'd like to welcome you all to today's webinar about extended cell-free DNA-based prenatal testing. I'm Kelly Lachenberg, the genetic counselor at Next Genetics. One of the main services offered by Next Genetics is non-invasive prenatal testing, and as you may know, we've recently brought genome-wide NIPT in-house, which is very exciting for us. TriScreen Plus is able to provide information about aneuploidies involving chromosomes 1 to 22, sex chromosomes and deletions and duplications larger than 7 megabases. TriScreen Plus utilizes Illumina's VeriSeq technology. So in view of this, we're very excited to welcome Dr. Lieve Page-Christiaens to discuss her experience with extended cell-free DNA-based prenatal testing. While I'm sure Lieve needs no introduction, as many of you heard her very impressive talks at our NIPT symposium last year. Just to give a little bit of background for those who weren't able to join us, Lieve worked as a gynecologist, fetal maternal medicine specialist, and associate professor at the University Hospital Utrecht in the Netherlands for 35 years. In addition to covering the whole field of obstetrics, she was also in charge of the prenatal screening and prenatal diagnosis program, as well as the pre-implantation genetic diagnosis program. Following her retirement from the university, Lieve joined the Illumina team as an associate director of medical affairs and clinical genomics. We're very privileged to have her speak to us today and share her wealth of experience in this area. Just before I hand over to Lieve, if you have any questions during the presentation, please type them into the question box and we'll answer them at the end of the presentation. Thank you so much, Lieve. We look forward to hearing your presentation.
Thank you very much, Kelly. And indeed, welcome to you all, and thank you for joining. In the current times, we might have to learn to meet each other in the virtual space. And whilst that has its challenges, it is so good that it is possible, and that even if we can't see each other's faces, we hear each other's voices and messaging. So it's a privilege for me. I'm based in the Netherlands, from the other side of the world, to talk to you this hour about things that I'm pretty passionate about and have been pretty passionate about the past years. My name is Lieve Page-Christiaens. I'm a fetal maternal medicine specialist, formerly at one of the Dutch universities and involved in the Trident study, and currently as an associate medical director at Illumina. In that function, I'm obliged to tell you that I'm an employee of Illumina, but I also want to reveal to you that what I'm going to share today with you are my opinions, and they might not necessarily represent the opinions of the company. I also want to emphasize what you all know, that non-invasive prenatal testing, even if it's very, very accurate, it remains a screening test. It is not diagnostic. And test results must always be confirmed, or at least confirmation tests have to be offered to the couple, to the patient, and no irreversible action should be taken before such a confirmation is done. That being said, I would like to do today, or to get across today to you, is information about the potential clinical significance of knowing about rare autosomal trisomies or even monosomies and large duplications and deletions in the genome of the placenta and or the fetus. And I would also like you to take home today some information on the potential impact of such expanded, we call it expanded NIPT results, on the clinical practice of those professionals who take care of the pregnancies. So with that in mind, I have divided my presentation in 4 sections. I like to start with a bit of personal experience, because that is the foundation of my conviction. What I've seen and what I've learned in the clinic is the basis of what I'm telling you today, and what I'm convinced that is worth pursuing, and convinced what is worth doing in the clinics for our patients. Then second, you can't prove things by cases. So second, I'll present some of the evidence that is available for the utility of expanded NIPT. I'll transit to our own technology, the Illumina test that Kelly just mentioned, that indeed allows to do a genome-wide analysis for aneuploidies in all chromosomes and large duplications and deletions. And I'll finish with what is the best ways to counsel women about such expanded NIPT. What should they know pre-test? What should we do if there's an abnormal test result? Who should explain that test result, and how should it be handled? My personal journey. As I said, I worked at a university hospital, and I have done pre-test counseling in lots of patients. The policy during the first years that we were allowed to do NIPT and it was reimbursed was a contingent model. That means patients first had first trimester combined test, and thereafter, if the risk was elevated, they had a choice between NIPT or invasive testing. And as you probably imagine, most of them chose NIPT as a second test. The drawing that you see on the screen and that I keep there for a while because I really want you to absorb it is the drawing I used in the pre-test counseling, and with my directions it was drawn by the hospital artist whose name you see at the bottom and who gave me the permission to use it for presentations. And I like this drawing a lot because it explains exactly the key issues with NIPT and the key characteristics. And it's very helpful if women have this in their mind when receiving a result. It shows that cell-free DNA comes from the placenta, the little green bits of DNA. Next, it shows that these little green bits of DNA come in the maternal circulation and are tremendously diluted there because there's a lot of maternal DNA in there as well. That's the second characteristic that is important for women to understand. And the third thing it shows is that, at least with some technology, like the Illumina technology, you then align all these bits of DNA along a normal reference genome, and you can see whether at a given point there is eventually an excess indicating an elevated risk, or a higher risk, I should say, for trisomy 21 here. But it also illustrates that the same can be seen anywhere in that genome, just as we used to see when we did karyotype in chorionic villi or in amniotic fluid. So it's not a really new concept. It's something that we've done before. It comes from the placenta and it is diluted with maternal DNA. Three very important concepts that you can come back to when informing a patient about a result. The organization in the Netherlands, we started in 2014, and all university laboratories, that's 8 laboratories in the country, participated in what was called the Trident 1 study. We didn't quite know what to do to offer targeted analysis for the 3 major chromosome anomalies, or to offer genome-wide analysis. And because these were genetic, sorry, I have a bit of a drink. Because these were genetic laboratories, most of them were interested in doing genome-wide analysis. So 6 laboratories offered genome-wide analysis, and 2 laboratories, amongst the 2 was my laboratory, decided to, for the time being, only offer targeted analysis. And now I come to my first case. My first case was a patient referred because of an abnormal first trimester combined test result, 1 in 45, with a PAPE of 0.5 multiples of the median. We performed cell-free DNA-based NIPT at 14.5 weeks and the result was normal. A mid-pregnancy ultrasound scan, though, showed multiple very discrete anomalies, and I show you one on the slide. That's a clubfoot. But there was also clenched fist, as you see in trisomy 18. There was a dilation of one of the atria in the heart, and there was a dilatation of one of the cerebral ventricles. The patient who wanted certainty asked for an amniocentesis, which was done. A rapid aneuploidy test for 13-18-21 was normal, but the karyotype and the SNP array showed a mosaic trisomy 8. And that is a syndrome that is well recognized. It's rare. It comes with severe features, amongst others mental retardation, but also organ anomalies. And the patient requested termination of pregnancy, which happened at 21 weeks. The bioinformatician, who was very interested in seeing whether we would have seen this had we looked at it, opened the run and found a trisomy 8 signal of a score of 21. And when you know that the threshold is 3, you realize that this is really an abnormal result, and we could have been aware of this 6-7 weeks earlier. As you all know, termination of pregnancy at 21 weeks is quite different from terminating in the first trimester. And the earlier you terminate pregnancy, the least emotional an experience it is, but also the least medical impact it has eventually on future pregnancies. So here it would have been extremely useful if we had done a genome-wide analysis in the first trimester. We would have been informed much earlier about this severe anomaly. The second case was the NIPT test failure. And as I said, in those early years, we didn't quite know well what to do, and we were very interested in the bioinformatics. The bioinformatician opened the whole run. That means he looked at all the chromosomes to understand why the sample failed. And he saw a trisomy in one of the denominator chromosomes, in chromosome number 7, again with a very, very high Z score. And because that was a denominator chromosome, a chromosome that we compared chromosome 21 with, it disturbed the scoring and it failed. We offered the patient an invasive test, but she declined. And because in old literature of the 80s, it has been described that a placenta with an extra chromosome can lead to growth restriction. We decided to follow up the growth with ultrasound very, very carefully and to take actions where appropriate. The growth was not very nice during the whole pregnancy, but at 36 weeks, there really was a growth arrest. The baby didn't grow at all. And in consultation with the colleagues and with the other departments, we decided to induce labor, and a baby of 1,600 grams was born. And you all know 1,600 grams at 36.5 weeks is way too small. The baby did well, didn't have to go to intensive care. The woman only consented in doing a FISH for chromosome 7 in the baby, and it didn't have a trisomy 7, but the placenta had a trisomy 7 mosaic. More importantly, and that's what you see at the right-hand side of the slide, was the pathology of the placenta. The placenta showed an extremely rare pathology called maternal floor infarction. It's a bit of a misleading term because an infarction is usually a blockage in a vessel. But with maternal floor infarction, it's like a crust of calc. It's a crust of fibrin around the villi, preventing in the end all oxygen exchange between the mother and the child, and very often, if not always, leading to fetal death, unexpected and unannounced, suddenly, without the baby first moving less. Suddenly the babies die. I'm pretty convinced that in this case we have saved this baby's life by knowing and by monitoring that pregnancy so carefully. And there's meanwhile many reports of fetal growth restriction associated with trisomy in the placenta. And I'll show you more of that. My third case, and the last case, is a large deletion in the long arm of chromosome 3 detected by NIPT in the current study cohort. And there was no anomalies at ultrasound. We checked whether the mother had abnormalities and she didn't. And the amniotic fluid confirmed that the baby had a de novo deletion of chromosome 3 in the long arm. The phenotype of this deletion is known and was explained by the clinical geneticist: delayed development, epilepsy, and dysmorphia, all things that you cannot see by ultrasound. And I think that's an important message, that is that some of the rare chromosome anomalies do not come with ultrasound anomalies and therefore will not be detected by a 20-week anatomy scan. So far, my cases. These have formed, as I said, the base for my conviction that it is worth to look at other chromosomes, but 13, 18, and 21 as well. But of course, you can't prove a point by just listing cases. And it's correct to ask the question, but what is the evidence? As you can imagine, these are extremely rare events. And to collect evidence, we will need a collaborative effort. But that being said, the evidence is there and the evidence is growing. The first question one can ask: how frequent are these anomalies? Are they frequent enough to test for? And we have a very good study that we frequently use, and that is the study of Diana Wellesley, published in 2012 in the European Journal of Human Genetics. And she looked at European congenital anomaly registers to determine the frequency, the relative frequency of various chromosome anomalies. And you see the synthesis of her data in this slide. And as you can see, rare chromosome anomalies are as frequent as trisomy 18 and 13 together. So rare indeed, but not negligible. The second question is, these were live births that you have just seen. But if we look in the first trimester prenatally, how frequent are they going to be then? And this is a study from Mr. Konialis in Fetal Diagnosis and Therapy, and he looked at 80,000 amniotic fluid analysis and 10,000 chorionic villus analysis. And what he sees, and of course these are elevated risk patients, otherwise they wouldn't have had a chorionic villus sampling, but what he sees is 5% autosomal trisomies, 0.5% rare trisomies, and 0.75% partial deletions, duplications, markers, so structural anomalies. Again, a frequency that is low and lower than the classic trisomies, but still not negligible. In total, like 1.3%. I go a step further. We've had the liveborns, the chorionic villus analysis, and how is it then with NIPT? If we do NIPT for all chromosomes, what will we find in different populations? These are the condensed data of Trident 1 and Trident 2. The Trident studies are the studies in the Netherlands. Trident 1 looked at elevated risk. That was the case for my first patient that I described. So first trimester combined test, if the risk was above 1 in 200, then followed by NIPT. And you see reflected here what you've just seen in the chorionic villus data, that is that the frequency of rare chromosome anomalies is around 1.6%. In the chorionic villus sampling data, it was 1.3, so that corresponds pretty well. In the all risk group, the Trident 2, the frequency of rare autosomal aneuploidies and structural anomalies is 0.34. Again, correspond with figures that we expect. Why is this important? I think it's very important to demonstrate that if you do NIPT genome-wide, so expanded NIPT in an average risk population, the screen positive rate will not increase tremendously, 0.34%, and that is confirmed by other studies as well. So we will not lose the big advantage of NIPT, that we don't have to offer invasive testing so often anymore. So we will not lose that advantage since the screen positive rate will only modestly increase. Are these aneuploidies associated with clinical pathology is the next question to ask. There is I think like 16 publications out there, but I choose to present you for today the paper by Ben and his colleagues in 2019, who summarizes 6 papers that have good follow-up data. And that is, of course, important that there's good follow-up data, at least of the abnormal results. The paper only describes rare aneuploidies and not the segmental aneuploidies, but gives a good view of what the clinical pathology is associated with finding a rare aneuploidy. What you see here is over 70,000 samples with 194 rare trisomies ending in miscarriage, confirmation in amniotic fluid and abnormal, not confirmed but still an abnormal phenotype. That could be a hidden trisomy in the fetus, fetal growth restriction as an important risk, and a normal outcome in these cases only in 41% of cases. And again, remind, these are publications that altogether have a follow-up percentage of the abnormal results in almost 80%, which is very, very good. So Peter Ben, as many others, showed that at least half, up to 60% of pregnancies where a rare trisomy is identified have an abnormal outcome. Some of these are actionable. The fetal growth restriction, for instance, as I have shown in my second case. If you're aware of that risk, you won't send the woman to the midwife. You will do regular ultrasound measurements, and you will action if you see that a baby's growth is compromised. If there's a miscarriage, you will know what the cause of miscarriage was and be able to use that for further counseling and further eventual testing of the woman. If there's a fetal anomaly, the woman and her partner have the choice whether or not to pursue the pregnancy or to choose the place of delivery in the proximity of a newborn ward, for instance. So there's all sorts of actionability during pregnancy, just after birth, or even in preparation for a next pregnancy. I do want to stand still a minute at the question, but what if the rare autosomal trisomy is only found back in the placenta? Because this situation is not infrequent, that the rare autosomal trisomy is limited to the placenta and is even mosaic in the placenta. This is a study from Australia of more than 23,000 cases, and this study shows 2 things. That is that fetal growth restriction is very often associated with a rare trisomy when there's also a low PAP-A. And the second thing it shows is that this situation is not limited to chromosome 16. Those of you who have been reading some of the literature, the recent literature, will have come across the statement that only trisomy 16 is a problem and that the others are not. Well, this is not true. If you look at this publication, you see that growth restriction came with 4 or 5 different trisomies. And if you look at all the publications together, ones on this subject, you'll see that miscarriage occurs with a number of trisomies. Congenital anomalies are seen with a number of trisomies. Chromosome 8 should be in that list as well. Growth restriction is associated with a number of trisomies, and so on. So the problem of rare autosomal trisomies is not limited to chromosome 16. This sentence captures it very well. I think a placenta with an extra chromosome is not a normal placenta. It leads to miscarriage. Certainly, if you do the NIPT early in pregnancy, you will see quite a bit of miscarriages. If you do your NIPT later, like at 12 weeks, it will be associated with later fetal demise, with congenital anomalies, with spontaneous preterm birth. Virtually no child with a trisomy 16 in the placenta is born at term, and with fetal growth restriction. A small standstill at the technology that is in place nowadays. The VeriSeq Solution Test version 2 that we have launched past year allows to detect classic trisomies and rare chromosome anomalies above 7 megabase. The question has been asked whether something changes to the test performance if you use this test in what we call the genome-wide mode. You can use VeriSeq NIPT Solution in the basic mode. Just look at trisomy 13, 18, 21 and the 6 chromosomes, or you can choose for the genome-wide mode. And that can be done per sample. So for the laboratories, it's important. They don't have to do a whole bunch of patients in the same way. No, per patient, the choice can be made. And the question is, if you go to that genome-wide mode, does the test remain as sensitive and as specific as it is in the basic mode? And the answer is yes. But I do add something. The answer is yes if you exclude mosaics. Because as you can imagine, if there's a low-grade mosaic, hence only 2 or 3% of abnormal cells, then the signal of trisomy 21 will become very, very weak. And one might miss such a trisomy 21 mosaic with all technologies. All technologies suffer from this problem, that a low-grade mosaic will be missed. So when you exclude the mosaics, the performance is exactly the same, and the performance is extremely good. You best look at the bottom line where the confidence intervals are, because that gives the real picture, taking into account the numbers or the low numbers of the trisomies 13 and 18, for instance. Sensitivity is extremely good. For the rare anomalies, I have included the mosaics because the rare anomalies are much more frequently mosaic than the classic trisomy 21, 13, and 18. And you see that for all these anomalies together, the sensitivity due to the mosaics is indeed a tiny bit lower. I have in our validation study that was done for VeriSeq NIPT Solution version 2, I have listed the mosaics for the classic trisomies. And what you can see here is that any mosaic lower than 50% has a big chance to be missed by the test, whilst mosaics above 50% have all been detected. Our mosaic score, though, has not been validated well enough yet. This is only 11 samples, and you need a huge number of samples to be able to say where the cutoff is for detection of mosaics, and that's ongoing work. finally, how difficult is it to explain this to patients? I've been there. I've done this many, many times. And the Dutch Trident studies have really taken a big effort to make the pre-test information for patients very, very good, but also feasible for the counselors, and to design a post-test trajectory that takes extremely well care of the patients and makes sure that the anxiety or uncertainty is limited to a minimum. For pre-test counseling, we live in an extremely good era and an extremely good time, because there's lots of digital and other means that can help us and that can help the expectant parents to prepare. And we're very happy to tell, and you'll hear that from Next Genetics as well, that the NIPT Insights app will be available in South Africa as well, for free, downloadable on the App Store or Google Play. And it's an app, unbranded, that helps patients to prepare for the consultation with the counselor, to prepare the questions, to get some basic information, and to start thinking about their choices. We have developed, we didn't develop it, but we funded the development of the app, and we had it translated in multiple, in France, in the Netherlands, in Belgium, and now also in South Africa. For the consultation, I've always found this type of books helpful. This is an Illumina book, but there's also other organizations having what we call a flip book or a counseling guide that you can use during consultation with images that help explain things to the patient. And this is an extremely witty one, because the side that the counselor looks at has some text to help, and the side that the patient looks at just has the images. Imaging is a very powerful tool to explain and to make sure the patient absorbs what you're saying, and eventually you can make a copy and give it to her to take home. We mustn't forget that genome-wide aneuploidy testing is not new. So those in the clinics, the clinical geneticists, but even the midwives, the OBGYNs, and of course the geneticists, have been counseling about rare chromosomal anomalies for all their professional lives. So it is not new. We've seen it in CVS much more than with amnio, and to explain this to patients are at hand. And I can't resist making the comparison with ultrasound. If a nuchal translucency is measured, we might see anencephaly, top left image. We might see megabladder, to the right of that. We might see a big omphalocele, or very echo-dense intestines. We might see a dilated pilum, or something in the brain, or something in the heart. So genome-wide or fetus-wide assessment is not something new. Only prior to an ultrasound, we rarely explain, and the woman is rarely aware that also sad things can be seen on her ultrasound. This is 2 bits of text, one for the pre-test counseling situation and one for the post-test counseling situation, explaining about what in the Netherlands is called secondary findings. And secondary findings are the rare chromosome anomalies, the ones that prenatal screening was not primarily developed for. And there's 3 things that I've put a little frame around. It states that these anomalies are so big that they usually have serious consequences. It states that follow-up testing is needed. And it states that if a woman chooses for that extended testing, about 4 in 1,000 will get the information that there is a secondary finding. And I think this is very much the essentials. No need to tell more, no need to tell all the details of all the possible anomalies. that is not relevant at this point in time. If the woman realizes that this is about rare but serious things that will need follow-up testing and what the risk is that she will be confronted with it, that is enough for the pre-test counseling session. For the post-test counseling session, it is important to leave her in uncertainty as short as possible. And a very good strategy, therefore, is that when she hears the result, she has someone with knowledge on the phone straight away, and not someone who just brings the message and then can't say anything more. So the Dutch Trident study has chosen for the following strategy. When there's a rare chromosome anomaly, the geneticist phones the patient, even if the patient has never seen that geneticist. The geneticist phones, explains shortly, briefly, and makes an appointment at very, very short notice, so that the time to go on internet or to talk with the family is as short as possible, and she gets professional, accurate information about the given findings straight away. And I would add to that that in the same session, an ultrasound should be made, because if the pregnancy is young, very often it will already be a miscarriage, or you will be able to see anomalies, or you will be able to say there's no anomalies, and that will give further guidance to what the advice will be as to follow-up testing. So combined ultrasound with a genetic counseling or a geneticist conversation is what has to be done or scheduled for a post-test counseling. We as a company, we tried to be helpful here as well, and together with a big team of counselors, clinical geneticists, and myself, we have designed what we call the physician information sheets. And for every trisomy, it's a bit of a small print, but this is for trisomy 20. For every trisomy and also for monosomies in general, and for some microdeletions, we have developed a physician information sheet that has references, additional recommendations, and can give a first guidance to the physician who receives a rare chromosome anomaly result. So my conclusion, it's time to conclude and give you time for questions, is that rare chromosome anomalies are as frequent as trisomy 18 and 13 together. They do not increase the screen positive rate with more than 0.5% in the average risk population. And they can result in an increased risk for pregnancy loss, miscarriage, or stillbirth, for birth defects that are not always detectable by ultrasound and that are not always associated with high-risk biochemical results, intellectual disability. And this implies not only to chromosome 16, but to almost all chromosomes. And I think if this is what you retain from this session, that would be great. And I thank you for listening. And I'm open to questions now.
Thank you, Lieve, for such an excellent presentation. I think your insight is so valuable and is going to make a significant difference to our clinical practice. We have a few questions that have come in, if you're happy to answer them. So the first one is, what clinical consideration should be taken into account when deciding if an extended panel should be done? Is age a factor that you would consider?
Well, not really, actually. I think there's a number of clinical situations where, as an OBGYN, I would even insist a bit on extended or expanded NIPT. The most important one is the abnormal first trimester combined test result, especially low PAP, but also elevated ACG. Because it's very clear that rare trisomies are associated with placental pathology in quite a considerable number of cases. And low PAP and elevated ACG are also signs of placental pathology. So if those are present, I think you have a special reason to offer expanded NIPT. And as you have seen in the slide comparing Trident 1 and Trident 2, you could see that in Trident 1, 1.6% of the cases with an abnormal FCT result had a rare trisomy or a segmental aneuploidy. 1.6%, that's considerable. Age, not really. Another group that could apply for extended testing and that I haven't talked about is the carriers of a balanced translocation where the segments are large enough to be seen with NIPT. And that is not a formal indication in our instructions for use of our test because of lack of huge experience, but I know that some of our customers are using this successfully. I can only hope they will publish that soon. I would never do that without consulting the laboratory. So if someone has, for instance, a carrier of a Robertsonian translocation between 14 and 21 or between 13 and 14, those are big segments that have been exchanged. Very often, these, when affected, these pregnancies end in a miscarriage. So these women may have had a number of miscarriages already, and they are very wary of having an invasive test that, for the risk of miscarriage. So these women welcome, they embrace a non-invasive test. And you can see these large segmental aneuploidies very, very clearly when unbalanced. But you as a laboratory should be consulted before promising to the woman. You should be enabled to look at the chromosome analysis of the parents, to look at the size of the segments, and to decide whether you're comfortable doing that. And preferably also keep track of those cases and publish them later, because this is new terrain, but certainly a meaningful application. And age, no, I would add the woman's desire to have genome-wide testing, because most women come into the office with the question, can you help me avoid, or can we help me getting this pregnancy to as good an end as possible? I would like a healthy baby. That is how people come into the office. They don't come into the office, can you avoid me having a Down syndrome baby? They come with a wider question. So if it's the woman's desire to be informed as broadly as possible, that is probably also a reason for offering genome-wide testing.
Thank you, Lieve. That's so true. That's the first most patients say, is they just would like a healthy pregnancy. And while this can't guarantee it, it can definitely help provide some information. We did actually have a question about structural rearrangements as well, which you've already answered for us. Thank you. And then the next question we have is, does the same apply to results on the extended panel at low fetal fraction as it would to the standard panel, so that we're able to give results at a low fetal fraction?
That's a very, very good question. I haven't touched upon a limit of detection, because that is what this question is about. How low may the fetal fraction be to reach the limit of detection of the assay? And in fact, the threshold of 4% has been labeled as such for other technologies than the whole genome sequencing technology. There is technologies that really need a substantial fetal fraction to allow accurate test reporting. And the fetal fraction that is needed for technologies differs by technology. The threshold is different by technology. We have the big advantage that we sequence all these bits of DNA fragments, and in one patient we might have 10 million of these fragments, whereas in another patient it might be 6 million of these fragments. And the sequencing, the number of sequenced fragments also plays a role, as you can imagine, in the accuracy of the test. So if we have lots of fragments but a rather low fetal fraction, that can still be enough for giving an accurate result. So we could eventually report at 2.2% fetal fraction. Whereas if the number of sequenced fragments is very low, say 2 million or 3 million, and the fetal fraction is also low, then we can't report. So we do not fail a sample just on fetal fraction. We take fetal fraction and sequencing depth together, and depending on whether that combination gives a sufficient number of reads to be abnormal reads to be counted, we can give the result. And that is the same for basic and for genome-wide. That doesn't change. The algorithm we use is, as you know, called IFACT, and that's just a name that has been given, but we use IFACT for failing a sample based on fetal fraction, and IFACT takes into account the fetal fraction and the number of sequenced reads.
So much. And then the last question that we have is there any data available about false positive rates for the extended panel?
Yeah, I apologize. I didn't stand still. It was on the slide. The specificity is 99.7%. So the false positive rate, sorry, the analytical false positive rate is only 0.3%. But there's something else than the analytical false positive rate or specificity here. If you talk about false positive rate for the extended panel, you have to define what we are talking about. There's the analytical false positive rate, so the test misses something, but there's also what are you comparing with, because to state that something is false positive, you need to have a golden standard. And if your golden standard is amniotic fluid, the false positive rate will be higher than if your golden standard is chorionic villi, because some of these rare trisomies are limited to the placenta, are confined to the placenta. So ideally, there's probably three sorts of false positive rates. The one that is to do with the analysis, the one that is to do with the tissue you're comparing with, and eventually also the one that is to do with the outcome of pregnancy. And that differentiation should be made in literature as well, that if we talk about positive predictive value or false positive rate, we should specify what we are talking about. And the false positive rate will be much lower if you talk about outcome of pregnancy than if you are talking about amniotic fluid analysis, for instance. But analytically, it's 0.3%.
Okay, thank you. And then one more question that has come in. Can genome-wide NIPT be done on twin pregnancies?
Yeah, that's also a very good question. Whereas the number of publications on twin pregnancies increases, and there's also already done meta-analysis showing that twin pregnancies can be tested with NIPT. The number on twin pregnancies for rare chromosomal anomalies is very limited. What you have to take into account when offering this to twin pregnancies is one, it's good to look at the chorionicity up front. In monochorionic twins, you can see that with ultrasound very reliably in the first trimester. With monochorionic twins, these are monozygotic, so it's identical twins. There's no problem. but with dichorionic twins, those can be dizygotic, and eventually these twins have lower fetal fractions, so your samples will fail more often. That is something that the woman has to know. But on the other hand, first trimester combined test performs very, very badly in twins, and invasive testing has probably double the risk of invasive testing in singletons. So NIPT is still the better of two choices, combined with ultrasound assessment of chorionicity, and combine the information to the woman that she's more likely to experience a failure of the test.
Thank you so much, Lieve. We haven't had any other questions come in, so I think all that's left to say is thank you very much for your presentation and for being willing to answer all our questions. Thank you so much for everybody that joined us this afternoon. I hope you found it as informative as I did, and stay safe. Thank you.
Yeah, it's my pleasure. I hope to meet you all once and again. And if there's questions coming up later, you can always pass them on via Next Genetics, and I'll answer them.